Welcome to Essential for Me. I'm your host, Joanne, and together we're going to be on this journey to discover what is essential for your well being.
Essential for me.
More than 4.2 million South Africans have this chronic disease, and more than 50% of this 4.2 million do not know they have it. Let's talk diabetes with endocrinologist Dr. Zane Stevens. Welcome, Dr. Stevens.
Thank you for having me.
So, those are alarming stats to hear and to know. What is diabetes?
So they are very alarming.
Yeah.
The word diabetes simply refers to the fact that a person has a high level of blood sugar. But how that sugar actually becomes high depends a little bit on the type of diabetes that they have when we diagnose them. And our sugar is maintained by a group of hormones and insulin. So yes, diabetes means a person has a high level of blood sugar. And that exposure of our cells to high blood sugar over many years, if it's not controlled, leads to damage to cells and the so-called complications of the condition.
Okay. Doctor, you mentioned insulin and you threw around blood sugar and glucose. Can you please explain how does this work in our bodies?
Absolutely. So if we think about it, our bodies need a constant supply of energy. Even when we're not doing anything, our heart is beating, we're breathing, and our cells need energy on a continuous basis. And that primary source of energy is sugar, or glucose as we refer to it. And to be able to get the glucose into the cells where the body can then burn that to produce the energy we require, insulin, which is produced by the pancreas, a gland in our stomach, on our abdomen, is released. And in a way, it's nice to think about insulin as being a key to a lock. And what that insulin then does is it opens up the cells so that the glucose, the sugar from the blood, can enter those cells and then be used to produce the energy that we require.
Okay. So are we then saying that if you are diabetic, the insulin is not there, so the sugar cannot be absorbed and used within the cells? Is that what we ultimately say?
So what you're referring to here is, broadly speaking, then the sort of types of diabetes. But essentially, yes, the issue is that either there's a problem of there not being insulin, which is in a way what we call type 1 diabetes, or there's a problem that that key doesn't fit the lock, which is a nice analogy to what we would refer to as the concept of insulin resistance. So that person still has insulin. Often, actually, if we were to measure it, not that we suggest that people do, but if we measured the insulin in a person with insulin resistance, often that level of insulin is high because the body is actually trying to overcome the fact that this key just isn't fitting the lock. The person still needs that glucose to go into the cells, and the body compensates by making more insulin to overcome that resistance. And that is usually what we find in people with type 2 diabetes.
So if you could just elaborate on that, doctor, the difference between, and I know you went into a bit of detail now, but between type 1 and type 2.
Sure.
Yeah.
So it's often remarkable to me that people have been living with diabetes for many years and they actually themselves don't know the difference. So this is really important. So type 1 diabetes means that this person's body is not making enough insulin. And the cause of that in the largest majority of individuals is what we refer to as a disease of autoimmunity. So their immune system incorrectly starts to identify the little cells of the pancreas that usually make the insulin as being foreign to that individual. And their immune system over many years attacks and damages those little so-called beta cells of the pancreas that produce the insulin. So when that person comes to our attention as having a high level of blood sugar, it's because their body's not able to make insulin anymore. And so then therefore makes sense. The only way that we can treat such an individual is with insulin, because that's the hormone that they are lacking. In contrast, and by far the most common type of diabetes, more than 90% of individuals living with diabetes would have so-called type 2 diabetes. And this is usually driven or started by this concept of insulin resistance. So their body's cells are just not responding to that insulin that's being produced. And that's usually in the setting of overweight and obesity that's driving that process. So that's the difference.
Yeah. Doctor, if you're looking at type 1 diabetes, would we say that genetics plays a very big factor into that autoimmunity that you speak about?
Absolutely. So type 1 is a far more genetic condition. In routine clinical practice, it's not something that we do, but we know that there are certain genes that are associated with type 1 diabetes. We can, for example, say that if a mom has got type 1 diabetes, on average, a child of hers would carry a risk of about 2 to 3% that child would also develop type 1 diabetes. Interesting enough, it's slightly more if the father has type 1 diabetes. But the point being that there's a strong genetic link to this condition. Type 2 diabetes we often refer to as familial. So it's not just one gene that is affected, it's sort of small snippets of various genes, which results in often multiple family members being diagnosed with type 2 diabetes.
Okay. And also, of course, like you mentioned, lifestyle also factors into that.
Absolutely. So type 2 diabetes, if we think about the risk factors, it's usually a combination of a genetic predisposition. It's not as strongly genetic as we've just said with type 1 diabetes, but there's a family history. And if together with that predisposition, a person unfortunately ends up following a less healthy lifestyle, as they age, gain weight, particularly if they're gaining that extra weight around their middle, so-called sort of central overweight or obesity, I would tell patients it's not the fat under the skin that's causing the problem. They might not like the way that looks, but what that tells us is that this individual is at risk of laying down fat internally, so-called visceral fat. So that fat is fat that's laid down, for example, in the liver, around the pancreas. And it's this deep visceral fat that promotes this development of insulin resistance and that key not fitting the lock. And this person's blood glucose starts to go up.
All right. Quite interesting. I've heard of this term actually not too long ago, pre-diabetic. What does that mean? And is it almost as a certain sort of state that you're going to be diabetic?
So that's exactly the reason why we don't actually like the term pre-diabetes. It is used in the literature, but it's not a term we like because in a way it tells this person that it's inevitable that they will develop diabetes.
That's what I hear.
And that's definitely not the case. So what people refer to when they're referring to pre-diabetes means a level of blood sugar that is between normal and diabetes. And there is that gray area. So when we're testing somebody for diabetes, we look at various things. We look at a test called their fasting glucose. And we would say that a fasting glucose of up to 5.5 or 6, depending on the literature, would be a normal blood glucose if you wake up in the morning and you've not eaten anything. 7 and above would be indicative of diabetes. And so that small area in between means that this is somebody who is, I like to think of it more of at risk of diabetes. So that would be one of the screening tests, for example. There are others which we can perhaps talk about. But the concept of pre-diabetes means that this is an individual at risk. But I think it's important to underline that does not mean that there's no turnaround here. If this person can change their lifestyle, particularly focus on weight loss, if that's the driver of their risk, that this person's blood glucose can entirely normalize. In fact, people even who are diagnosed with diabetes can go into so-called remission of their diabetes through lifestyle changes. So it certainly does not mean that this person is on a path to diabetes that cannot be turned around.
Thank you for clearing that up for me, because it almost sounds as if, it's your path.
It's inevitable.
Yeah, it's inevitable. Exactly. Your path has been determined. This is the road you're going down. Doctor, once you are diagnosed a diabetic, how often should you go for your checkups? How often should you see a doctor?
So maybe we talk mostly about type 2 diabetes when I answer this question, because that's by far the most common type of diabetes that people would be diagnosed with. And as with all questions in medicine, everything can be answered with "it depends." And the "it depends" here, I think, relates to the fact it depends on how well controlled an individual is living with their diabetes. So even if somebody is doing very well, all their numbers are in target, their blood sugar is well controlled, their blood pressure is well controlled, their cholesterol is well controlled, those individuals should still be engaging with their doctor at least twice a year. So we've got guidelines in South Africa, but they're very much the same as in the rest of the world, of certain tests and checks that need to be done once a year and certain tests and checks which need to be done twice a year. So at a minimum, an individual should be seeing their doctor twice a year. But if they're not at target, as we like to say, if their blood glucose is not where we would like it to be, it's important that that person would be seeing their doctor more regularly to get them to that place where they are now in target. Because what we want to do with good control of diabetes is through a combination of lifestyle changes and medication as indicated. We want to prevent the complications of that person living with diabetes. That's the goal. We want to make sure that they don't lose a single day of their life. Because you mentioned some scary statistics earlier.
Yeah.
But if you are diagnosed today as a middle-aged individual with type 2 diabetes, on average, you've lost 7 years of your life.
What?
If you are even less fortunate and develop a significant complication like a heart attack or a stroke, on average, that person has lost 12 years of their life. And the sadness, if you think about it, those are years that they're supposed to be enjoying with their grandchildren after they've retired. And we don't want people to lose any of those golden years. So the goal is to get people impeccably well controlled so that we win back. And we can. We really can.
Yeah.
We want to win back those years that they may lose if they are not well controlled.
Yeah. Doctor, you spoke about some other complications now, and I would really like to dive into that. So being diagnosed with diabetes, how does it make you vulnerable to other complications as well?
Sure. And this is really what it's all about. So if we think about diabetes, in a way, it affects blood vessels.
Yeah.
It's a disease of damage to blood vessels. And we can think about it as damage to large blood vessels. And I think most people are aware of the fact that being diagnosed or living with diabetes puts you at risk of heart disease, strokes, and amputations.
Okay.
And so these are the damage or the complications that we can see to large blood vessels in the body. But equally so, small blood vessels are affected. And here we talk about the back of the eyes, the so-called retina. We use the term retinopathy. And diabetes is still actually the leading cause of blindness in most places in the world. These small blood vessels that supply blood to the nerves can also be affected. We call this neuropathy. So patients may experience tingling, loss of sensation, those types of symptoms, particularly in the feet initially.
Yeah.
And then the blood vessels that supply the kidneys. This leads to a complication which we refer to as nephropathy or diabetic kidney disease. So these are the organs that we want to protect through controlling people's blood glucose very well. But it's also important to realize that when we're managing or we're treating people living with diabetes, it's not just about the blood sugar. Many individuals with diabetes will at the same time have other diseases of lifestyle, which include high blood pressure and high cholesterol. And it is the combination of all of those conditions that lead ultimately to the complications. So when you're seeing your doctor, we're not just going to be talking about how well are we doing with your blood sugar day to day. We need to be talking about how well are we doing with your blood pressure. Is there a need for you to be on a cholesterol-lowering medication? Because it's a holistic approach that's required in the long-term management.
That's definitely what I'm hearing. It's just, it's linked to so many other factors in your body. So it's a holistic approach.
Completely.
Yeah.
Completely.
Doctor, speaking about approach, will we find diabetes only amongst adults or children as well? And with approach, is that different to children then?
So type 1 diabetes, the less common form, the form where we treat with insulin, tends to be diagnosed in children and young adults. However, it can actually occur at any age.
Okay.
We used to only diagnose type 2 diabetes in sort of middle-aged and older adults. And we used to actually say that age was probably the most important risk factor for the development of diabetes. But that has changed. We are aware that overweight and obesity is now the strongest risk factor. And if you think about the prevalence of overweight and obesity in children and in teenagers increasing, unfortunately, we are now starting to diagnose type 2 diabetes even in children and in teenagers. So that is changing. In terms of the treatment approach, in those young children and young adults, it's the same. Importantly is weight management, weight loss, if we can assist with that through lifestyle interventions. But we use the same medications largely in those younger people with type 2 diabetes as well.
Doctor, just out of curiosity, what was your youngest patient that you had to...
So I am an adult endocrinologist, not meaning I'm an adult. Hopefully that can be seen. But as an endocrinologist, I treat people 13 years or older. So, but I have seen a 13-year-old with type 2 diabetes who has unfortunately also been living with overweight and obesity. So, which in itself is also a chronic disease. And I think that's important for us to maybe talk about at another point. But so we're seeing this younger and younger, unfortunately.
Yeah, no, it's really unfortunate. And, just getting into maybe stress and trauma, and I actually want to share a scenario with you. I know of someone who diabetes is in the family, but once this person experienced stress, trauma, the passing of the mother brought on these sort of emotions and feelings, this triggered type 1 diabetes. What I want to know is this a coincidence, or can we find that stress and trauma sort of, trigger us into an early state of diabetes?
Sure.
Yeah.
So it's fascinating. And this is very typical in type 1 diabetes. If you take a careful history, there often is a stressful life event, a divorce, a motor vehicle accident, something that happened in the couple of months leading up to this diagnosis. And sometimes it's not necessarily a psychological stressful event. It could be a physical stressful event like a motor vehicle accident or a severe infection or something like that. So if we think about how that might work, we said that that's a quite genetic condition. So again, you're born with the genes that could result in the disease. At some point, something's got to trigger that genetic potential, and these might be such triggers. So we do often encounter that in the history of somebody who's diagnosed with type 1.
And if we look at mental health as well, I'm just thinking about, for example, if someone is depressed and they might be sleeping much more than the usual person, which means you're not getting in, you're not eating correctly, you're not getting enough nutrients. How does that also affect, a diabetic state?
So mental health is so important, so important in anybody, both type 1, type 2 diabetes. It's so important, and it affects their disease in many different ways. So firstly, we know from good scientific data that the stress of living with a chronic condition impacts on your mental health.
It's really stressful.
Very stressful. I often think to myself, I get up in the morning, I go to gym, stop at the coffee shop, have a coffee with quite a bit of milk in it, go to work. And that's just sort of the first 2 hours of my day. Imagine doing the same thing, but thinking all the time about what my blood glucose is. I wake up in the morning, I've got to test my blood sugar. Perhaps I had a low blood sugar early hours of the morning because of the treatment that I'm on. I've got to now correct that, recheck my blood pressure when I get to gym to see if I can exercise based upon what my blood sugar is.
It's a lot of work.
It's a lot of work. So it's important to understand that will increase the risk of depression in people living with chronic diseases. But the other way is also important. If you are depressed, your ability to engage with your chronic disease, look after yourself, is going to be impaired. So one of the things we as doctors often do is, if we're struggling to understand why a person is not doing well with their disease, not doing well with their diabetes control, we screen them for depression, because that might be the factor that's leading to them struggling. So there's a very strong connect between mental health and diabetes.
Definitely. What advice would you give someone, or what tools would you give them to sort of deal with these pressures, whether it be stress or, mental health?
So I think the first thing to just say is, it's common. You're not alone. And you're not a failure. You're not looking after yourself. It's almost expected at some point in your journey with this condition. And I think that takes away a lot of that stress.
I was going to ask you, is that almost the first hurdle to get over?
Absolutely, is to know you're not alone. And the second thing is, there's actually a website about diabetes distress. And patients can actually do a questionnaire and sort of identify the fact that, hang on, I'm not really coping at the moment. And so I think patients also need to take that responsibility to say, listen, I'm in trouble. I'm not coping here. And that might result in your doctor referring you to a mental health professional if it's indicated. But I also think it's really important to share your burden. Your family, your friends would be very happy to chat to you and talk to you about things which you're struggling with. And so I think sharing that burden of living with a condition is important. And very often gives a whole family an opportunity to make lifestyle changes that are really going to keep them healthy.
I agree. Yeah.
So go walk as a family and exercise. Change how the family eats. I get so irritated when patients tell me I have to now eat so differently to my husband or to my children. No. How we want you to be eating, living with diabetes, is simply a healthy way of eating that everybody should be doing. You don't have to have a completely different diet.
Because it's not a diabetic diet.
No, it's a healthy diet.
How you're just being more conscious about what you're putting into your body.
Absolutely.
Yeah.
Absolutely.
Great.
Yeah.
Doctor, what are the latest advancements just with regards to treatment?
So I must say, this is probably, as a doctor, one of the most exciting spaces to be in.
Yeah.
Things have changed so radically. I've been in private practice now for 10 years, and things have changed unbelievably. So modern treatment of diabetes is now no longer just about getting the sugars well controlled. That still stays important. But on top of that, we have better and better medications that now no longer just control blood glucose, but actually literally win back those life years we spoke about earlier that people lose. So there are indications for certain medications in diabetes, such as medications if you have heart disease associated with your diabetes, or if you have kidney disease associated with your diabetes. We have drugs that then are organ saving on top of being blood glucose lowering agents. So it's really a very exciting space to be in, because we are helping patients to live longer by being on the correct medications. There's also been a big shift, if we look at people living with type 1 diabetes, of better ways of monitoring their blood glucose, because one of the biggest barriers to keeping yourself well controlled is you've got to prick your finger 6 or 8 times a day. That's incredibly painful.
Yes.
and it's often a barrier to good control. So we now have more and more access to wearable monitors that send information to a smart device like your phone, just making it so much easier to be engaged with your diabetes on a day-to-day basis.
I'm sure as technology is advancing, we'll be able to see more sort of modifications to what will be available to people that have diabetes.
I often say to people who are now diagnosed with type 1 diabetes that they've got to hang in there. Within their lifetime, we're going to have a plug-and-play artificial pancreas. And that's on the horizon. So there's a lot of change that's coming.
Sure. Doctor, what is the link between diabetes and pregnancy?
So we know that globally, about 14% of all pregnancies, and in certain populations significantly more than that, of women who are pregnant are diagnosed with what we call gestational or pregnancy-induced diabetes.
Okay.
So if you think about the kind of physiology behind it, some weight gain is normal in pregnancy.
Yeah.
Absolutely. But if you perhaps go into that pregnancy already with a higher than normal body mass index, the additional weight gain, together with the hormonal changes that happen during pregnancy, push that insulin resistance to a state where that person's blood sugar actually starts to rise above what would be entirely normal. Okay. And that is what we refer to as gestational or pregnancy-induced diabetes. So if you think about it, 70% of women in South Africa have a body mass index that is either overweight or obese. Mm-hmm. So we have a very large number of women who go into a pregnancy at a higher than healthy body weight. Okay. And so we have a large number of women who are diagnosed with gestational diabetes. And the problem with that is there are issues for the baby and there's issues for mom. Yeah. For the baby, the most common issue is that if you just think about it, the baby is exposed to high levels of sugar all the time. So these are large babies when it comes to delivery. So they are more prone to complications during birth, immediate complications after delivery. And I always say to a woman, this is for you a big, big red light. Because studies have shown us between 40 and 70% of those women who are diagnosed with pregnancy-induced diabetes, if you follow them over 10 years, will go on to develop type 2 diabetes later in life. So it's a wonderful time to intervene as a doctor, because we're not just sort of impacting on mom's health in the long term. Studies have also shown us that if these children, these babies, during pregnancy are exposed to high levels of sugar all the time, as adults, they are much more likely to be overweight, obese, develop type 2 diabetes. So if we can control that mom's diabetes in pregnancy well, we improve the health of her offspring throughout their life.
Wow. So not just mommy that's affected, but
baby
too.
also in a big way. Yeah.
So, doctor, are you ultimately saying that, for example, once the pregnancy term has been served, the mother can return to her usual health?
You make it sound like a prison sentence. So typically what we find is if this is just sort of pure gestational diabetes, and, sometimes actually it's not. Sometimes this is a lady who had undiagnosed type 2 diabetes that she didn't know about. Now, she's seeing a doctor because she's pregnant, and we identify that diabetes.
Again, part of the 50% that didn't know.
Exactly. So it's an opportunity for screening. But pure gestational diabetes, we usually would diagnose in the second half of pregnancy classically. And as those pregnancy hormones kind of return to normal, usually by about 6 weeks after delivery, if we retested that mom, she is no longer diabetic by definition at that point. And that would be sort of the classic gestational diabetes. So it's driven by that combination of weight gain, often some genetic predisposition. There's often a family history of type 2 diabetes in these young women. And then the sort of the stress of the actual hormonal changes of pregnancy.
Okay. Doctor, in your opinion, is there enough awareness and prevention around diabetes in South Africa?
I think we can always have more. Absolutely. I think what we probably don't do well is screening. I think most people kind of have some concept of what diabetes is. I think, it's out there. But I don't think everybody is screened appropriately, sees their doctor or has some kind of health check, because this really is one of those conditions you want to diagnose early. Because if we can diagnose it early, we can prevent all of those complications from happening. On average, unfortunately, the day that we diagnose somebody with diabetes, they've often had it for quite a few years before they were even sort of identified. And in all of those years, their cells have been exposed to high blood sugar all the time. And that means that they may even have complications when we diagnose them.
Doctor, when you say that they haven't been screened appropriately, has this got anything to do with access?
I do think so. I think, in South Africa, the largest majority of our population is looked after in the state sector. And I'm not at all suggesting there isn't screening that's happening, but I think we miss some of those opportunities. So we should be screening more. But even in the private sector, patients, it's remarkable how late we often diagnose the condition. So no, nobody's immune. We probably are missing many people for far too long.
But also, like you said, just in terms of awareness and getting the message out there, we can never do that.
No,
there can never be enough of
more.
that.
We can always do more.
Because when you know better, you can do better, hopefully.
Absolutely.
Right. Doctor, I think a topic that has been trending, I would say, for the last, I would say year. It's about the type 1 medication that some people have been using that are not diabetic, but they are using it to reach sort of, I would say, other goals, might be weight loss. Your opinion on this?
So maybe just to correct you, it's a type 2 medication that you're referring to. So we have a wonderful class of medications in type 2 diabetes, which we call the GLP-1 therapies. So technical, but GLP-1 is essentially a hormone that all of us have produced in our gut. And this hormone does three important things in the body. Firstly, when we eat food, which is going to become sugar, it actually nudges the pancreas to make insulin, and that's why these drugs are so effective at controlling blood glucose. But they also result in weight loss, because what this hormone is supposed to do is slow down how quickly food passes through the stomach and communicate with a part in our brain called the hypothalamus, where we get that feeling of I'm satisfied.
Yeah.
And so many people living with type 2 diabetes, as well as those who are overweight and obese without type 2 diabetes, have lower levels of this hormone. And so these treatments improve blood sugar and they do facilitate weight loss. So look, these drugs are registered. Certain of them are registered for the management of overweight and obesity in people who don't have diabetes. And there's no issue. They're excellent medications. The problem and this is globally, it's not just in South Africa, there are stock shortages of many of these medications. And then it becomes kind of an ethical question about whether we should be using them only for people who are diagnosed with type 2 diabetes or also people who are managing their weight. And that's more of an ethical question, but they are very, very effective medications for both diabetes as well as for weight management.
Right. So I'm not hearing any harmful side effects really that you'll be exposing yourself to.
No, in fact, in some of the very large studies of these medications in people living with overweight and obesity without diabetes, they reduce the risk of cardiovascular disease. So they're going to slow down the risk of you having a heart attack or a stroke by helping you become more healthy through losing weight and improving all of your metabolic conditions. So no, there are complications to them, which we, tell patients about as they start those medications, but the largest majority get over that phase. Initially, they're mostly kind of some nausea, headache, and other gastrointestinal side effects. But we help patients across that initiation phase, and most will do very, very well on them.
Okay. So, Doctor, if we're getting into the, prevention conversation now, what would your advice be regarding that for diabetes?
So I think the most important thing that we can do is talk about lifestyle changes that are required to prevent yourself from developing diabetes. And by far the most important thing is to maintain as healthy a weight as possible, because it is that excess weight, so overweight and obesity, that drives the development of diabetes. And this really then is something that needs to start in childhood. So we need, and these are not things that, medicines can do. These are things that sort of at our government levels, we need to be getting children in schools to be taught about healthy eating, about remaining active. I mean, when I was at school, and probably you as well, we had to do sports after school.
Yeah, compulsory.
And today, I think we live a life that is much more sedentary. People are not as physically active anymore. Yeah. We live in a world which is sort of really geared towards people gaining extra weight. There's food around us all the time.
Yeah.
And I think that those are shifts that need to be made. So maintenance of as healthy a weight as possible is important, and probably the most important thing you can do to prevent yourself from developing diabetes in the future.
Would you say that a healthy knowledge of, nutritional food would be an advantage to sort of combating diabetes?
I think understanding calories, probably, if I'm honest, is the most important thing, because I find it fascinating how, sometimes a burger could be less calories than a wrap that's sold to us as being particularly healthy.
Really? Because you would think I need to go for the wrap instead of the burger.
Exactly. Yeah. So I think it's we should all be able to read, the labels on the back of food. And at the end of the day, when we're talking about prevention of diabetes, I've already said I think weight management's the most important thing.
Yeah.
A calorie is a calorie.
Yeah.
So you want to limit the number of calories if you want to try and facilitate some weight loss. And so understanding what a calorie is and sort of how many calories there are in one food versus another is probably the most important piece of dietary information you can have. Once you are diagnosed with diabetes, obviously it's a little bit more nuanced in a way, because certain foods are going to be pushing up your sugars more. So there starch foods,
Okay.
foods that are obviously very refined sugars are going to have a bigger impact on your blood sugar in people living with the condition already.
Yeah. I think you'd almost have to see a dietitian, or am I incorrect when I say that, to kind of understand,
Sure.
the breakdown of, food in one's body.
I think specifically when you're diagnosed with diabetes, I think seeing a dietitian is a very important part of the process of looking at how you can change the diet. A dietitian would also be very helpful if you're struggling with weight management to teach you about those calories. So absolutely, a dietitian plays an important part here.
Yeah. Doctor, what are the biggest barriers, in your opinion, that the biggest barriers for South Africans to manage, diabetes effectively?
So I think here the access starts to play some roles. So unfortunately, if we look at sort of specialists in the country, they are fewer. Okay, so most individuals who are living with diabetes are going to be managed by their general practitioners. And seeing GPs regularly is important. Okay. As we said earlier, every 6 months if you're well controlled, more so if you're not well controlled. And very often, unfortunately, even those with medical insurance, there's a limited number of appointments that you're allowed to have with your doctors. So sometimes access is a barrier. I think within the sort of state sector, where a large number of patients are looked after, access again becomes an issue. So that's a problem. But a very big problem in South Africa is we do not have a lot of what we call diabetes educators. So in other parts of the world, these can be nursing sisters or sometimes dietitians as well, but they are people trained to educate people about their diabetes management. And I think these are incredibly important and often can achieve even more than a doctor can. That's to my point. And in South Africa, unfortunately, within the South African Nursing Council, we don't have training for people specifically in terms of diabetes education. And I honestly believe that these individuals would make the biggest impact. And it's something that we should be focusing on. I often look back, we come from historically in this country, a place where HIV and AIDS was sort of a very bad past for us. But we really turned that around with clinics that were driven by nursing sisters. Patients living with HIV and AIDS, even to this day, don't see a doctor at every visit. They see a qualified nurse who checks their adherence to treatment, makes sure that their blood tests are done. And we really have changed the lives of people by having access through nursing care. And I think that model is something we really could be looking at in the diabetes space. It would make a huge difference.
Doctor, can I ask, the reason for that, is it because the nursing practitioners are sort of in the field on the ground? Is that the real difference? Why is that so effective?
Look, I think patients often feel a little bit intimidated when they see their doctor. Whereas, and I'm very fortunate, I have a practice where I have a diabetic nurse educator working with me. And we always chuckle a little bit to ourselves about the things that the patient feels comfortable talking to her about versus I always get the perfect story. and Jocelyn, the sister who works with me, she gets the real story. And the truth is obviously somewhere in between. So I think it's about the patient feeling so much more comfortable. Also that we have there would be potentially more nurses, and I think we could reach more people that way. So I think it really would make a huge difference.
Do you think that finances or the economy of this country also comes into play? I think a lot of people might think that buying good food is
expensive,
way more expensive, and they'll really buy and eat what they can afford.
Absolutely.
Which will lean more towards your, preserved types of food.
Look, and I think that there's truth and not truth to that. So I think in general, yes, healthier whole foods may be more expensive. Sort of very low quality, calorie dense foods are less expensive. There's no doubt about that. But I think here education becomes an issue again, in the sense that people can be taught how to use fruit and vegetables more effectively,
Yeah.
and to manage their health, nutritionally that way as well. So
Okay.
understanding that certain foods are not necessarily bad for you, even though a potato is a starch. If we looked at sort of just the quantity, that makes a big difference. So yes, I think that there's an education component to diet that's lacking, but it is also true that unfortunately sort of foods that are kind of bad for our health, if I can call it that way, tend to be cheaper.
Yeah. I really think it all boils down to awareness and education that's going out there, because then you'll kind of be able to be empowered to make the decisions.
Completely. If you understood that sort of vegetables are healthy for you, you need a very small piece of ground to grow, a couple of your own vegetables, which would be then less expensive. So no, I agree with you. Awareness and education is vital.
Yeah. Dr. Stevens, thank you so much for your contribution to, I think, a very important topic. Like you said, the stats are alarming. And I think the more we get to speak about this, the more awareness we'll raise about diabetes.
That's the hope.
Yeah. There we go. So to conclude this conversation, remember that you need to exercise, you need to eat healthy. So check those diets and also take those supplements to optimize good health.